I am thrilled to welcome Lisa Marsch. Dr. Lisa Marsch is the director of the Center for Behavioral and Behavioral Health, the director of the Northeast Node of the National Drug Abuse Treatment Clinical Trials Network, and a professor at the Geisel School of Medicine at Dartmouth College. I've asked her to come talk about tech tools for preventing and treating substance use disorders. It's just a little after 11. We have her until 11:55, and I'll turn it over to Dr. Marsch right now. And she'll have a presentation, and we'll have plenty of time for Q&A. So Dr. Marsch, welcome, and thank you very much for coming.
Great, my pleasure. Well, thank you so much for the invitation to join you all. And it's just terrific to see the strong interest this group has in addiction and the state of the science in addiction care. So I appreciate the opportunity to be part of these meetings. Can you see my slides okay?
Yes, we can.
Okay. Great. So thank you again, Chris, for the invitation. And as Chris mentioned, I'm going to be speaking about the application of technology to substance use disorder prevention and treatment, something called digital therapeutics, which I'll define for you. So in addition to my academic affiliation at Dartmouth College, I wanted to acknowledge that I have an affiliation with a few small businesses that are involved in developing and deploying various digital health tools. Our research center has a number of industry partnerships. And I want to acknowledge the funding for the work that I'll be mentioning today. We have been very grateful to the National Institute on Drug Abuse, including our center grant, which is all about the application of digital technology to substance use disorder treatment. And there's the website for our research center. It's a national center. It's housed at Dartmouth, but we have partners across the US and internationally that work with us. And for folks who might be interested in this topic, we have an array of resources that might be of interest to you at our website. So I'm talking about digital technology, and as we all know very well, digital technologies, things like mobile computing, cloud computing, and data analytics have really fundamentally transformed how our society works, how we do education and finance and social relations and retail, how we have conferences now. And so the work that we do is largely in the space of how can we leverage digital technology in redefining how we understand health and provide healthcare. So digital therapeutics is a term that refers to clinical grade software that is effective in preventing, treating, or managing a disease or disorder. So this is software that literally embeds within it sort of active therapeutic processes in the content and the functionality of the software to deliver an effective prevention treatment or disease management intervention. So you can take things like cognitive behavioral therapy and offer it in an interactive way on software, or teaching people problem-solving therapy, or giving them skills for medical regimen adherence, or in the case of prevention, providing interventions and skills training to build up protective factors and reduce risk profile for, let's say, prevention of a substance use disorder. So these are not simply wellness apps. We know there are a lot of wellness apps out there, but rather they take sort of an evidence-based, clinically validated model of care, often behavioral therapy types of approaches, and deliver it via a seamless digital delivery platform. And I'll give you some very specific examples as we go along. So what is a potential utility? So this software, if it's indeed clinically validated and accessible, we see that it can extend the reach and the impact of clinicians. So it's another tool in the toolbox of clinicians that they can make available to their patients as a therapeutic resource on demand, accessible to them even when they're not with their clinicians. Kind of can supercharge the clinician workforce, if you will. So it's kind of like a therapist in your pocket, 24/7 accessible on demand. And there now is quite a lot of research that shows that these digital treatments can greatly improve patient outcomes. And that's not just true of patients in treatment for substance use disorders, but we've seen this across many patient populations and health domains. Importantly, it can deliver treatment in a way that ensures fidelity to best practices. We know there's a lot of variability in terms of how people deliver care in the real world, and we can ensure that sort of the state of the science is reflected in the way that these tools are delivered. And we see all over the world, really, virtually any population you can think of either has access or is expected to get access to mobile devices. In addition to the work we do in the US, we do work in low and middle income countries. We might work in communities that literally don't have clean water or landline infrastructure, but they often have mobile devices. And so it's just a opportunity to harness the widespread availability of these devices to think about how to expand personalized healthcare resources. So the idea is that we could have scalable science-based behavioral healthcare anytime and anywhere. And of course, we've seen that during the last year, during the global pandemic, we've seen that remote models of care have become more important than ever. And certainly we've seen not only just a surge in the telehealth space, but also in the digital therapeutic space in terms of research in this space, in terms of what's being done clinically, in terms of industry investment in this space. There's been really extraordinary growth in the last year. So relevant to our topic today, there now has been probably about 2 decades of research that has looked at the clinical utility of digital therapeutics for substance use disorder treatment. And this slide summarizes sort of the big picture of what we see in that scientific literature. We've seen that if these digital treatments are developed well and really have clinical utility to their target audience, we see high usefulness and acceptability to many diverse audiences. We've seen a really robust impact on lots of types of health behavior and health outcomes that we can replicate in lots of different contexts, including substance use behavior. There is now a pretty substantive literature that shows that digital treatments can produce outcomes that are as good as or sometimes better than clinician-delivered treatments. So some people really bristle at that and say, oh, you're trying to replace clinicians with computers or with technology. And as we think about sort of the addiction workforce or even the behavioral health workforce more broadly, we really don't have enough capacity in our workforce to meet our population level needs. And that's been even more evident in the last years with the opioid crisis. And so to know that there are active ingredients in these therapeutic tools that really can help improve patient outcomes is very important as we think about how to extend and the impact of our clinician workforce. We've seen that you can increase quality, reach, and personalization of care. We've seen that these can be cost-effective in many contexts. And importantly, they don't always have to work the same way. We don't always have to have 12 sessions of this therapy or 8 sessions of that, but we can sort of embrace what technology can do and have adaptive and flexible interventions that over time can be responsive to people's changing needs and preferences along their clinical trajectory. So I'm going to give you an example. There's, if you go to our website, we have many examples of digital therapeutics, but I'm going to give you one example in the interest of time of a digital therapeutic that we had the opportunity to first develop the first iteration of it probably a couple of decades ago, but it's been studied very extensively in lots of rigorous scientific studies funded by the National Institute on Drug Abuse. And I want to demonstrate for you as an exemplar of a digital treatment, sort of what kinds of clinical impact this can have when it's offered as part of care models. So this, the research version of this was called the Therapeutic Education System. And just briefly, it's a pretty intensive behavioral treatment for substance use disorders. So it's based on a model of therapy called the community reinforcement approach to substance use treatment. And this is a very strongly evidence-based, one of the gold standard behavioral therapies for helping people change self-defeating patterns of drug use. And it really focuses on helping people understand and disrupt harmful sort of behaviors and cognitions that perpetuate drug use behavior. And it teaches, and it has a lot of sort of reinforcement built into it, where people learn to leverage personal and social and vocational resources to help initiate and sustain changes in drug use behavior. It also includes, sort of consistent with principles of behavioral economics, it includes incentives. Sometimes they're called motivational incentives, sometimes they're called contingency management, where you can give people reinforcers contingent on achieving milestones in their recovery, like participating in therapy sessions or like providing urine results that are negative for problematic substances. So it's sort of a positive incentive system that is now automated, and it's entirely in the content of this digital therapeutic. So there are lots of sessions. It's got like 60 some different sessions. It's a pretty intensive behavior change intervention. And again, if folks have questions on the details of this, glad to talk about it, but I highlight it here as an example of an interactive software that has been studied in many ways for and many settings for treatment of substance use disorder. So I'm going to walk you through a few examples of NIH-funded research studies that have looked at different models of implementing a digital therapeutic in models of care and show you the patterns of results that we've seen in this line of research. So this is a study that it was a randomized controlled trial conducted with adults who met criteria for an opioid use disorder. And every single one of these adults was offered buprenorphine medication to stabilize brain neurochemistry of folks with opioid use disorder. But where they were randomized to one of three conditions was on the accompanying behavioral treatment they received on top of the medication. So if they went into the condition that's reflected here in the blue column, those participants received individual counseling 3 times a week, one-on-one sessions with a clinician who was extensively trained in this community reinforcement approach to behavior therapy, ensuring it was delivered with fidelity to best practices. If they went into condition that's reflected in the red column, they had a clinician, they checked in with them every other week, but the bulk of their behavioral treatment was done in an interactive way using the software, using the digital version of this gold standard behavioral treatment. And then if folks went into what's reflected in the gray bar, they received standard counseling, which was reflective of the kinds of standard counseling you often see in outpatient treatment programs in the US for opioid use disorder. So this is an example of one result from this study showing that even when you offload the bulk of the therapeutic intervention to a digital platform, we see comparable clinical outcomes to an exclusively clinician-delivered version of that therapy. Both of these sort of evidence-based treatments, a digital and a clinician-delivered, produce significantly better outcomes than standard treatment. And this was as measured through objective assessment through urine toxicology data, looking at opioid and cocaine use. So that's one example. I'll show you a few more. This was a study with adults who were entering outpatient methadone treatment for opioid use disorder. So in methadone treatment, they either went into treatment as usual, which as you likely know is daily methadone medication, along with the kind of counseling that can be offered in that setting. Or they went into a condition where they received methadone daily, but in terms of their counseling, their clinician-patient contact time was cut in half, and the other half replaced with access to the digital treatment. So let's say instead of meeting with a therapist for a 60-minute therapy session, they meet with them for 30 minutes, then they spend the other 30 minutes interacting with the digital therapeutic. And as you see from this graph, when you cut in half patient clinician contact time and replace it with this evidence-based digital therapeutic tool, you have significantly greater abstinence from the problematic substance of opioids relative to treatment as usual. So we had markedly improved clinical outcomes when you replace some clinician time with the technology tool. And we can talk about why this is the case, but basically you're taking a strongly evidence-based intervention, delivering it with fidelity in an interactive way that's constantly sort of checking what people are understanding and how they're progressing and can be adaptive and responsive to them in that learning process. We actually looked at patient outcomes in methadone treatment for 12 months, and this differential you see here, where you have an advantage if you get the digital treatment as part of care, persisted for the entire year. Now here's a different design. Let's say you don't touch the underlying model of care. You just say, what if we give you a supplement to your treatment? What if we say, along with outpatient treatment for substance use disorder, we give you access to a mobile version of this digital therapeutic? So that's what we did here. Persons in the standard treatment receive medication for opioid use disorder and counseling, and those that are reflected in the blue condition on top of that also received access to a digital version of this intervention. And when we give people this simple software, when they enter treatment, along with the standard model of care, we see we were able to retain those patients in treatment much more of those folks in treatment than if they went into standard treatment. So here we're looking at the first 3 months of a treatment episode. When people walk in the door, what percent are retained for the first 3 months? And when you get the tool as part of care, you have greater retention in treatment versus if you don't. And we know treatment retention is a really important predictor of long-term outcomes, clinical outcomes. Same pattern emerged when we looked at urine results. We had more negative urine results for opioids if you got the tool as part of care versus if you did not. And then I'll just show you one more example of a study that was done on NIDA's National Clinical Trials Network platform. So it was a multi-site study conducted across many states in the US, 507 participants. This was done with really diverse array of polysubstance users, folks with stimulant use disorders, cannabis, alcohol, lots of combination substance involvement. So these folks were, if they were randomly assigned to receive the digital therapeutic as part of treatment, a portion of their standard counseling was replaced with access to the digital therapeutic. So let me walk you through the slide. Here's how the data are broken up. The top two lines reflect participants who are in this outpatient treatment program, who at the time that they joined this study were already able to provide urine samples that were negative for their problematic drugs. Okay, so these folks are coming in already having some abstinence under their belts. When those folks got the digital treatment as part of care, which is the top line here, there was a very slight increase in abstinence rates documented throughout the trial versus those who didn't. But the bigger, more robust effect is seen here. These are participants who come in actively using, they're positive for the substances they're in treatment for. And when those folks who are actively using join the study and receive the digital treatment as part of outpatient treatment, we see a much greater improvement in abstinence rates in that sample versus those who come in actively using and get standard treatment. There are many, many results from all these studies, by the way, and if anyone's interested in papers, I'm happy to share. We also see, like in other studies, that when you get the digital treatment as part of care, you get better treatment retention. So for folks who might not be aware, in the US now, there's a new category of medical devices called prescription digital therapeutics. So the FDA now can review safety and effectiveness data or efficacy data from rigorous clinical trials of software to say whether or not software can be prescribed, can actually obtain a label to say this software is effective in the prevention, treatment, or management of a disease or disorder. So a company can go with these data and seek a label, an indication to say that this meets that criteria and gets this authorization from the FDA as prescription digital therapeutic. So primary care docs, for example, or other addiction specialty providers can prescribe software as part of their care model. So the very first FDA authorized prescription digital therapeutic was in September of 2017. We worked with the company called Pear Therapeutics to basically take this example I just showed you of this therapeutic education system and basically deploy a mobile version of that that's been renamed to become the first prescription digital therapeutic in the US. And then a second version of that, specifically with an indication for the treatment of opioid use disorder, was FDA authorized in 2018. So I mention this because there has now, since these dates, been a really marked growth in the number of groups that are going to FDA seeking prescription digital therapeutic status. There are many paths, by the way, to getting digital therapeutics out there. The FDA regulatory pathway is just one of them. But we have found that it's really useful for clinicians because if you look at what's in the App Store, it's really hard to navigate what's effective, what's not effective. There are like 200 wellness apps being generated every day on average. So the software that gets this designation, allows clinicians to know that this has gone through rigorous evaluation and sort of careful vetting through the FDA pathway in order to get this designation. Just FYI, in the last year during the global pandemic, there has been a really large increase in the availability of digital therapeutics, particularly in the mental health space, that the FDA has allowed to enter to the marketplace. And so this is undoubtedly a key part of the future of healthcare, and I think is only an area that we're going to see grow. So as consistent with the sort of topic we're talking about here, I'm highlighting for you all some examples of digital therapeutics for substance use disorders, but we and others have had the opportunity to develop, test, implement digital therapeutics for many types of behaviors, not only sort of behavior change interventions, but preventative health types of interventions. And we see the kinds of patterns I just showed you for substance use, we see can generalize, and we see similar sort of broad utility to many different health domains. And I just want to show you an example of how you can think about scaling this up. So we're doing a project in Latin America now where we're really trying to expand access to science-based mental health care, particularly for very prevalent issues of depression and very high rates of alcohol use. But if you look at the mental health workforce in Colombia, for example, which is this country we started in, it's very, very limited. So when you have a high need but limited workforce, how do you really scale out access to effective resources? And so what we're doing here is we're sort of fundamentally changing how mental health screening and care is delivered in primary care systems across the country by centrally leveraging technology as a way to sort of extend the reach and the impact of the workforce that is there. So this is a partnership with lots of partners, not only our group at Dartmouth, but lots of partners in Colombia, and not just research partners, but healthcare systems, insurance payers, and the Ministry of Health, and the World Health Organization, and the World Bank, and others. And I just highlight this here to show you that this type of sort of data that I showed you from clinical trials can really scale to think about healthcare delivery systems and centrally embedding technology into systems. So the way we've done this is there is some clinician training in primary care of what is depression, what is alcohol, what are the effective ways to screen for and provide treatment around this. But technology is used not only to automate the entirety of screening and assessment through using clinically validated measures, but also to provide a decision support system to guide a clinician through sort of best practices in treating the patient in front of them. And then also to have a digital therapeutic platform that can be directly used by patients who have depression and or problematic alcohol use. So in the interest of time, I'm not going to go into lots of detail about it other than to say, well, here's some screenshots of how they do the screening, how the tablets work for the clinician confirmation. This is the patient digital therapeutic, obviously in Spanish, that the patients can use in managing mental health conditions. So we've been implementing this and looking, we've basically gone from no screening for these issues at all in primary care in the country to doing it across many pockets of the country. And then the plan is to expand into similar kinds of work with partners in Chile and Peru. So I just mentioned this because I think also increasingly we're going to see this kind of thing evolve over time. So just the opportunity here is that we see that there's a transdiagnostic sort of benefit of digital therapeutics that cross many health domains. And it's an opportunity to think about how to scale science-based treatments and to do it in a way that can be used in lots of different settings and lots of different populations. And I just want to cover in the last few minutes before we move to discussion some other areas in digital health briefly, and we can speak about it more if you'd like in the discussion, but just want to put it on your radar. So I've been talking about digital therapeutics, this idea of anytime, anywhere treatment, but there's also quite a lot of work in using digital technology to screen and assess clinical conditions. We've seen for sure in the research world that when you use digital technology to do healthcare screenings, particularly around sensitive issues like substance use, we can not only facilitate validated assessments, but we have surely seen that we can much more often detect sensitive behaviors when persons answering these questions on a digital platform versus to a clinician. You get much more reporting of risk behavior. Telehealth surely is a big part of digital health, and as we know, this has increased markedly in the last year. But the last piece I just wanted to spend a minute on, because this is something that is growing rapidly and may be of interest to you all, which is this idea of how digitally derived data derived from like a smartphone or like a wearable, like a smartwatch, how we might understand the utility of different digital biomarkers that might help us capture information about an individual in a naturalistic setting that might have clinical utility, that might help us better understand clinical needs. So let me give you a little bit more detail around that. So there's growing work, lots of proof of concept at this point, but very promising results from a body of research showing that data collected from mobile devices, wearable sensors can capture a lot of rich information about individuals' behavior, health, and environment. Sometimes this is called digital phenotyping, where you get this granular moment by moment information about individuals as they live their daily lives. And it might be helpful to predict things that are clinically important, like if someone's in recovery from substance use, it might help us understand what confluence of factors might predict when they might relapse, or when they might not take their medication today, or when they might drop out of treatment. And the promise here, and this is what a lot of people are excited about, is not only does it give us a richer understanding of people's clinical trajectories in context, but also could allow us, if we can get sufficiently good predictive models, to understand when someone might be at risk of these events, and can allow us to trigger the delivery of a digital therapeutic intervention in real time and at the right time. That's the hope here, is that you can have sort of responsive interventions that are initiated when there's evidence of risk from digital health assessment. So this is sort of another way people are envisioning a rich data source that might be important as part of precision medicine initiatives. So I'll give you one example, and then we can turn to discussion. So here's an example. We're doing a digital phenotyping study that the National Institute on Drug Abuse is funding with patients who are in outpatient treatment for opioid use disorder, who receive medication treatment for opioid use disorder. So it's very exploratory. We are, with their permission, asking them to respond to different prompts we ask them to respond to on mobile devices at various points throughout the day. We are asking them to wear a smartwatch. And for people who are allowing us, we're actually taking their social media data, and we're doing an exploratory analysis to see what, if any, of these digital data might help us predict when someone might be at risk of relapse, or, as I mentioned, not taking their medication or dropping out of treatment. And sort of where is their unique contribution to these predictive models? Where is their redundancy? And so here's some examples. So from mobile sensors, we can get all kinds of information on smartphones about movement patterns, about sleep, about activity levels, and from smartwatch, heart rate information, and lots of features that can allow us to infer a lot of things about people's behavior. And then we ask questions, really quick questions on the phone, where we ask about their sleep and their stress and their current pain level and their withdrawal symptoms and their mood, and sort of who they're with, and their adherence to meds. And then for social media, we can look at texts and postings and comments, and we can look at topology of social networks and interactions. And again, this is exploratory, but for purposes of the study, so NIDA, the National Institute on Drug Abuse, has an interest in understanding, when we do clinical trials and we have these very specific clinical outcomes we measure, is there some way to supplement that by getting data like this from people's daily lives in this naturalistic context that allows us to better understand at a granular level sort of people's clinical outcomes? But also, as I mentioned, the idea in this field of sort of digital biomarkers and these predictive models is to see if we can learn enough at the individual level to predict when it might be best to trigger sort of these adaptive, sort of sometimes they're called just-in-time adaptive interventions on a digital platform. So I just wanted to raise that here, as this is an area that is growing, and the models are not perfect yet, but they're becoming better. And I think this is something that should be on our radar as a key part of the future of digital health. So I will stop there because I want to make sure we have plenty of time for discussion. This is our website for our center. Our research center is really charged with being a national and really international resource around the space of digital health as applied to substance use disorders. So the Center for Technology and Behavioral Health. So I have that website here if folks have any interest in checking out our resources, and surely glad to follow up with anyone after this meeting as well. So thanks for the opportunity. I look forward to your questions and comments.
All right, well, great. Thank you. That was great stuff. Got plenty of time for questions. First is Barbara, then we'll go to Madeline and Kyle. So if you're able to stop the share screen,
Sure.
and Barbara gets the first question.
Hi there, Dr. Marsch. Thank you for your presentation. I had a few questions. You were talking about this experimental digital phenotyping. Are you doing that at Dartmouth? And then I have another question as well.
So the question is, are you doing it where? I didn't hear the rest of your question.
Out of Dartmouth College. Are you doing it out of your university, or where is this research being done?
Oh, okay. Yeah, so it's a collaborative team on that project. Some of the researchers are at Dartmouth, but we're doing it in partnership with Kaiser Permanente and recruiting participants from that healthcare system. And we also have a group at IBM that's partnering on part of the analytics around this.
And then the question is about the reset and the reset O. Honestly, I haven't heard of either of these digital apps. I do cover this field a lot. I know they're FDA approved, but how widely used are they? How can someone access that?
Yeah, it's a great question. I'm not part of the business model of Therapeutics, so I don't know what their current distribution is. I think in the early years they had like tens of thousands of people that they were prescribed to. And it's a prescription, it literally is a prescription model where a physician, and it might be changing, but when it launched, a physician had to be the one to prescribe it, not unlike they were prescribing a medication. And then they get access to basically a 3-month sort of dose, 3 months of access to the digital treatment. And if you look at the FDA's sort of website, and they just launched a Digital Health Center of Excellence recently as well, the FDA did, you can see lots of other digital therapeutics that have become authorized in the US as well, heavily in the space of mental health. And in fact, they reduced their restrictions in terms of what the requirements were to get that status last year. And it's not clear if it's temporary or not, but they did it intentionally because they said during the time of the global pandemic, they wanted to make more accessible mental health resources. So companies still had to have meet some level of their expectations around sort of what they needed to produce in order to get this status, but it wasn't at the same sort of bar that preceded the global pandemic. So there's been quite a surge in the last year. And I should just mention there are other pathways. It's just, as I mentioned, some people find this pathway really good because it helps you navigate, what has really solid data behind it and what doesn't. But there are other pathways. In fact, there are companies like Express Scripts, a big pharmacy benefit manager, for example, that started their own digital health formulary. And they themselves kind of do what the FDA does, where they vet and say, here's what we're going to pay for, here's what we're not. And they've been growing what's on their digital health formulary. There's another example of a partnership that launched recently between CVS and WellDoc, where they're doing a similar kind of thing. So there are other paths in the US, and surely there are other paths in other countries. Germany, for example, has been doing this longer than any other country, I think. And they have sort of national payment for these as part of routine care. So there are different paths. If folks are interested in this space, a really great resource I would recommend is the Digital Therapeutics Alliance. If you just search for that, Digital Therapeutics Alliance, they have it's a trade organization. We're not part of it, but we've partnered with them on different conferences and things. And it's a trade organization that really has a wonderful website with very accessible, like easy to understand language about, sort of this broad space. And they keep it very up to date about what's evolving in this space globally. So if you're interested, they're a terrific resource I've found.
Okay, next question to Madeline.
Hi, yes, I'm Madeline Beck with the Mountain West News Bureau. So I report for NPR stations around the Intermountain West. I was just wondering, I've done quite a bit of coverage of the increased access to telehealth during the pandemic. And obviously big parts of that were federal legislation, state legislation, and private insurance changes in what they'll reimburse. Will those levels of access, do you think, have any long-term effects to these digital therapeutics? Is that reimbursement and those kind of increase of access of telehealth, is that going to affect these kind of therapeutics in the long run?
That's a great question. I think that we've surely seen, by necessity, I guess, a growth in interest in sort of distance models of care. And so I think raising the visibility of that might also raise the visibility of the potential utility of digital therapeutics. But it's a different model, and it's very complementary to telehealth because, telehealth is like real-time communication with a clinician, whereas this doesn't require any real-time communication with a clinician. It's sort of, accessible 24/7. And so it could complement and extend telehealth models too. It's another resource that, is accessible to people on demand. And so I think that just like in the telehealth space, we've seen like, big surge in like venture capital investment in digital therapeutics in the last year. So I do think that sort of just broadly understanding distance care as the new norm, and thinking about sort of the future of care that embraces digital health, I think has become more prominent than ever. And I really truly think one day we're going to get to a place where we don't even talk about digital health as its own thing. I think it's just going to be embedded more into the fabric of how we think about health and healthcare, and that digital will be part of sort of multi-pronged approaches to care. So did that answer your question or?
Somewhat. I mean,
Yeah,
part
okay.
of it is just with what are the costs for something like this? If someone gets prescribed this, is there cost to them or is there costs to the provider that they would need to submit reimbursements for?
Yeah.
They get reimbursements for, like that sort of thing.
Yeah, my understanding is that there's still a lot of variability in that space in the US. So right now, CMS is not yet reimbursing for these, to my knowledge. There's a lot of folks apparently advocating for that, including, I think, this Digital Therapeutics Alliance organization. But there are a number of private payers that have embraced this as part of what they will pay for, and also big sort of employers making this available to their employees. But there's still a lot of variability. And I know that and also lots of healthcare systems that have been moving toward more value-based care models have, more openness to this kind of thing. But in terms of actually having reimbursement codes from like Medicaid or Medicare, that doesn't exist yet. But people in the field feel like there's some optimism to think that we'll get there, but I'm not sure about the timeline on that. So yes, it's not being reimbursed in the same way as telehealth because it doesn't have that real time of the clinician interacting with the patient. Yeah.
Right. Okay. And it's, I guess just as a last second thing, is there any like major providers that off the top of your head that are currently reimbursing, like any of the Blue Cross, Blue Shield kind of companies, or any big organization you can think of?
What would probably be helpful, and I'm not advocating for Therapeutics, but since they were the first mover in this space, if you go to their website, they have a whole list of payers that are paying, private payers and employers. If you go to their press releases, that's where they're really visible. And that might be useful to you. Yeah.
Yeah. Thanks so much.
Okay, sure. And pear is spelled like the fruit, P-E-A-R.
Kyle next.
Hi, Doctor. Thanks for making time. I'm with Gray Television's DC Bureau, kind of looking at the federal policy for our stations across the country, including WCAX, just a hop, skip, and a jump up I-89 from you.
Yeah.
Madeline kind of hit on my big CMS question. So one of the other things I want to touch on is how much of a challenge is access to devices. I don't have to tell you that in your neck of the woods, it's not very hard to get out of cell phone range pretty quickly. Is this something where, you could do your inputs and once it finds a signal, it could potentially upload the data at that point? And then the final prong, I was curious, you mentioned incentives that some of these apps provide for negative urine tests, et cetera. What might those incentives look like? What might those be?
Yeah, okay. Thanks for the question. And yes, I know all too well about the connectivity challenges in rural New Hampshire, but you're right. It's an issue in many pockets of the world and not just the US. And I think, we have been seeing pretty exponential growth in access to mobile devices, but connectivity remains an issue in lots of communities. And one of the things that like our research group is focusing on is how do you develop really rich therapeutic tools that can reside locally on devices that don't require real-time connectivity. So maybe when there is connectivity, they can pull down upgrades and push data and things like that, but that they can be clinically useful and accessible even when you don't have internet connectivity. That's not the only solution. But I think it's part of when we've seen this in some of our really rural farming communities in Colombia, as I mentioned, the work we're doing in this country of Colombia, same issue there in terms of maybe they have a mobile device, it might not be a smartphone, and they might not have good connectivity. So part of the solution is how you develop these tools, I think, so that they have broad accessibility. At the same time, we are seeing a lot of projections in increased access to devices and increased connectivity, even in some sort of traditionally underserved communities, but we're not there yet. And so it is the case that there's still going to be some digital access gaps, I think, in certain communities. And I think we are moving in the right direction on that, but it's not a panacea for sure. I think that's right. Your other question about incentives. So there's this whole field of, some people call it contingency management or motivational incentives, and it's just based on basic principles of reinforcement. When you want to increase the frequency of some behavior you want to see, you provide incentives contingent on the evidence of that behavior, and you don't provide it if that doesn't happen. So in the space of substance use treatment, sometimes incentives have been provided when someone's trying to, change their drug use behavior to help them incentivize them to help them initiate change and then maintain that change. So when you think about drug use, there's some immediate reinforcement from drug use, whether it's some, positive euphoric effect or just getting rid of withdrawal symptoms. There's some value to the person at that moment in time when they use drugs. But if they choose not to use a substance in the moment, there's not a lot of reinforcement for not using drugs in the moment. So the idea of incentives here is to say, okay, if you choose right now not to use drugs, we'll give you an incentive contingent on that choice, so that you start getting some pattern under your belt around, sort of being able to get a string of non-use. And so some people have studied this their whole careers, by the way, of how to do this and what are the best reinforcement schedules and such. But at a basic level, a lot of times it's just some like pleasant thing, like a rewarding item, like in the case of Reset and Reset I think people can get like gift cards to like Amazon or Walmart or Starbucks or things like that, as I understand it, based on using the program, and or clinical sites can use it if people say they're in treatment and they start providing urine results that are drug negative. So that's how it's typically been done, but different people do it in different ways. They can have vouchers that can be exchanged for different goods and services. And it might sound simplistic, but we have seen in the scientific literature a really, really big effect. If you do these reinforcement schedules well, and you deliver the incentives like very soon after you detect the behavior of interest, it can really impact substance use and help people in making that change of changing their drug use as part of treatment. And right now in the world, you all are probably well aware, we've seen such a surge nationally in stimulant use, and often co-occurring with opioid use. There are no effective medications. There are no FDA-approved medications for stimulant use disorders, but the most effective treatment that's been demonstrated for decades now in the treatment of stimulant use disorders is this kind of incentive-based care model. And the data are really compelling around that. If folks are interested, apparently there's a recent meta-analysis that just came out about this, so I could share it. But anyway, so it's been very heavily studied, and in the digital space, we've just sort of taken that therapeutic process and just embedded it in delivered it in an automated way in the digital context, which I think has been helpful to a lot of folks, because managing it with people in a healthcare setting is a lot more challenging than if you can sort of just streamline the whole thing to a digital platform.
So if I'm hearing you correctly, it sounds like there are, say, financial rewards as opposed to just say a digital gold star, which while that might sound like not much of a reward, it's been shown to stimulate how people stock trade, et cetera. Is it primarily financial rewards as opposed to just a yay on the screen, and who's paying?
Yeah, so a lot of the applications to date have been, some tangible reward. Not always. Sometimes it can be probabilistic, where you sort of have a chance of winning a prize, and you're only eligible for the chance if you, demonstrate the behavior of interest. And so sometimes it could be some encouraging notes or other things, and sometimes it could be on a probabilistic schedule, some actual tangible thing. One thing that we've been doing and finding some very promising data around that's relevant to your question is a line of research that is sort of focused on going social with digital therapeutics. So, a digital therapeutic really is directed largely at one person typically, and it has all these tools and tracking functionality and content for that person who's seeking to do some sort of behavior change. But we've been studying, what about if you extend access to a support group of your choosing? Maybe it's your sibling or a friend or your spouse, where as you are using the tools and doing the exercises in the software, that person can actually use it with you. They're walked through a science-based sort of therapeutic process with you, wrapped in this structure. And as part of that, we've been looking at motivational incentives and rewards delivered virtually by the social support network. And we've been seeing in that case, where it's non-monetary, that we can also see some really promising sort of effects on keeping people engaged in treatment longer and helping them, sort of in their recovery process on different outcome measures. So if you're interested in learning more about that, I'd be glad to share more info.
Really appreciate it.
Sure.
Okay, Alexis next.
Hi, I cover neuroscience for a publication called brainfacts.org, and I think you had a slide that was looking at comparing traditional clinician-delivered treatment, and then for some people, they took out some of it and it was replaced with the digitally delivered. And it seemed like there were improved outcomes, improved retention from that. I'm wondering, so in that instance, it seems like it's superior to care delivered by a clinician. And I'm wondering, why do you think that is?
Okay. Yes, the data have shown in some trials that you can get sometimes better clinical outcomes than clinician-delivered care. I think that is in scenarios where there's a lot of variability in what clinicians do, right? And we often know that, like in like the example I showed you in the methadone treatment program, it's very well documented that in a setting like that, there's a lot of variability in what people do. What they do might be very helpful and therapeutic. It may not be. It might be maybe iatrogenic, where there's basically not sort of really good care offered. There's lots of turnover. There's lots of challenges in adopting best practices in behavioral treatments in a lot of treatment settings. So I think this is largely driven by the fact that we're taking something that has all this empirical support from research, and we're taking all those therapeutic processes and ensuring that they are delivered in a way that ensures fidelity to best practices in an interactive way, in a way that's individualized to the person using it. So it's a way to, sort of standardize and scale the delivery of the most science-based treatments, which may not be routinely offered in other care settings. I think that's a big part of it. But that said, in most studies, we have found that it is useful to have a clinician involved in the care, and to even reinforce engagement with the digital therapeutic, that you get more usage and engagement when this is part of a broader model of care versus a standalone. Although I'm not trying to dismiss the utility of standalone, because we know only like 11% now roughly of people with substance use disorders in the US actually go to our traditional models of care. So there's an enormous opportunity and unmet need for, 90-some% roughly of people in this country that aren't going to go to care, may not have access, may not want to go because of stigma. So there's still, I think, and the data would support utility in these tools as standalone resources. And sometimes we've even seen that engaging in a digital therapeutic might, for the first time, be sort of a conduit to treatment entry for an individual. So I think there are lots of different flexible models of deployment that might be clinically meaningful.
Okay, next question to Miri.
Hi, thanks for your talk. I just had a question about the use of artificial intelligence or machine learning for digital therapeutics. So, whether these have been demonstrated as effective for substance use disorder or other conditions, and, whether you think they'll play a role in sort of the future of these digital therapeutics.
Yeah, great question. I do think they'll play a role, and they already are. There's a lot of work actually going on with different types of machine learning approaches to try to predict things at an individual level or a population level using digitally derived data. Most of the work to date has been in the space of mental health, various mental health conditions. And I think that there's a lot of promise there, where we can, with some degree of precision, have good prediction of like when someone might be at risk of, let's say, a psychotic episode, let's say for someone who's been diagnosed with schizophrenia, or when someone might be at risk of a manic episode, or things like that. So there's some promise there. The models aren't perfect. And yes, they have been started to be applied to the realm of substance use disorder. Some of the really great work in this space has been done at the Intramural Research Center that the National Institute on Drug Abuse supports. It's in Baltimore. And they've done a lot of really good work as applied to substance use. There's a lot of room for improvement in this science overall. It's still very early stage. There's a lot of proof of concept, I think, now. But in terms of being able to understand what are the key features to extract, what are the key variables to put in these predictive models? Do we get replicability in different, sort of studies? The field isn't really there yet, but the promise is there. And if you have specific interest, I could send you some examples of papers in this space that kind of might be give you sort of the big picture of what's happening, particularly around substance use.
Yeah, that would be great. Thank you.
Okay, sure. So if you just send me an email, I don't know, Chris, if folks have my email.
Yes, we've shared that with them.
Perfect. Okay,
Yeah.
thanks. Okay.
So I don't see any other hands up, but I have a question for you. I mean, are your colleagues? Well, Stephen's hand just went up. So let me give him the question. Stephen.
Oh, sorry. Thank you, Dr. Marsch. My name is Stephen Johnson. I write for Modern Healthcare Magazine. We're kind of a trade publication with the target audience of healthcare providers. I was curious as to how are these digital tools currently being used within the healthcare framework within the clinical framework in terms of, for addiction treatment?
Yeah, thanks for the question. So clinically, my sense is that there's still a lot of variability. I think primary care has been a group that has been increasingly interested in providing resources around mental health and substance use, and yet doesn't have maybe a lot of mental health capacity. So like, for example, providers of medication treatments for opioid use disorder, may offer these digital therapeutics on top of the medication that they're prescribing to folks in their care. But also, I do think that there's a lot of use in specialty addiction sector in sort of programs that are especially, substance use disorder treatment facilities. Outpatient largely is my sense of the landscape right now. But then also employer sort of wellness. There's some examples of sort of employee sort of wellness programs where employers are paying for access to these to their employees. So I think there's a lot of variability at this point.
Okay. Any final questions? Well, let me just ask when you walk around the hallways of ASAM conferences, are your colleagues annoyed that you're suggesting they might be replaced by one of these things?
Yeah, so I haven't been walking around the hall of conferences very much recently, but in the early days, I would tell you, when we first started this work, like probably the late 90s, we did get a lot of perceived threat, like from clinicians, like, are you trying to say that this technology can do what I've been specially trained to do? And it's resistance. That has changed dramatically, where now we see a lot of excitement, where people feel like this is another resource I can give to my patients when I'm not with them. It can reinforce what we're doing together. At 2 o'clock in the morning on Saturday night, if they feel at risk of relapse, maybe they don't have anybody to talk to, but they might have something in their pocket that can help them successfully navigate that moment. So we actually, in a lot of sectors, have been seeing a lot of excitement of this as a way to extend the work that clinicians do. But it wasn't like that 20 years ago, so it's changed a lot.